Hey guys, we're going to go over Minnesota Blakemore tubes and our practice for securing them. So Minnesota Blakemore tubes are gastroesophageal tamponade devices that can be used for bleeding esophageal varices, esophagastric hemorrhage for unstable patients who need this temporizing measure as a bridge to definitive care. Minnesota tube or a Blakemore tube is placed at the bedside by a provider verified by x-ray. There's a couple different types of tubes that you might encounter. What we have here is a Minnesota tube, and that's what's placed at Hopkins. There's a couple different portions to the tube. When it's placed, there's two balloons here. First balloon is inflated is the gastric balloon. This can be inflated, depending on the tube type, 250 to 500 milliliters. So the tube's placed by a provider verified by x-ray. This balloon is inflated and then tension is pulled on the tube with weighted traction. That pulls this gastric balloon up against the gastric fundus, the lower esophageal sphincter, to mechanically tamponade bleeding. If there's still active hemorrhage after it's been placed on traction, then the provider can inflate the esophageal balloon. The esophageal balloon's inflated to no more than 40 millimeters of mercury. The tubes have measurements on them. Typically, you'll find it about 40 centimeters. The end of the tube has a couple different ports here. So we have our stomach balloon, our gastric balloon. That's the one that's inflated in the stomach to up to 500 milliliters. You have your esophageal balloon. And then this is a Minnesota tube, so it has both a gastric and an esophageal aspiration port, suction ports. So when we're assessing our tube at the bedside, there's a couple things we're going to look at. When we arrive, it'll be on weighted traction. Traction can be applied with up to a 1 kilo weight like this. You might see a liter bag of saline used to apply traction. So we arrive at the bedside, we're going to get report, we're going to find out what type of tube they have, what the measurement is at, when it was verified by x-ray. We're going to verify that both of our balloons are double clamped, so one with a physical clamp, and then you might see a cap like this at the end of the tube. We're going to get in report how much the provider has inflated the stomach balloon. We never want to deflate this balloon because it'll cause the tube to become displaced. That's what's holding the tube in place, is that larger stomach balloon. And then we're going to, at the bedside, verify how much the esophageal balloon has been inflated using a manometer. So if the respiratory therapist who's there has a cuff manometer, that's great. You can use that with a Luer lock device like this. What we have here is another way to check. This is a cuff manometer that you can insert. You can take off your clamp. You should get an inflation reading right away. And if needed, you could inflate your tube again to no more than 40 millimeters of mercury. We want to make sure we leave that clamped. And your clamps should be rubber tipped, coated in gauze or something so that they're not actually digging into your tube like these ones are here. So now that we've verified our tube type, we verified that both of our balloons are appropriately inflated and double clamped. It's important to verify the inflation of the esophageal balloon because if it's overly inflated, it could cause tissue ischemia and other issues. So now we're ready to prepare our patient for transport. The way that we're going to recommend securing these tubes for transport is using a Hollister. This is a commercial tube holder that some of us might be familiar with. How you're going to have your kit supplied is with a Hollister that we've added an additional clamp on. There's a little butterfly clip here that you can just pinch to slide on your extra clamp, and then you have one for your ET tube and one for your Minnesota tube. If your Minnesota tube is nasally inserted, you could just slide this off, flip it around 180 degrees, and put it like that to secure a tube in the nose. So when we're preparing to apply this, we can leave our ET tube taped. There's no need to take off the ET tube tape because this is only going to be used for transport. And we're going to leave our Minnesota tube on weighted traction. So we can go ahead and apply our Hollister. You can also, obviously, you'll tape this to your patient's face. Okay, and again, this is still on traction. We can go ahead and secure our ET tube, get that out of the way. And then we can secure our Minnesota tube. So we're gonna get that on there. While it's still on weighted traction, go ahead and mark your tube at the insertion point at the lips. And now that we have it in our Hollister device, we can remove weighted traction by physically taking the traction off the end of the bed. You could leave the tie on there to make it easier for yourself. And then we're ready to transport our patient. So if your patient's like edentulous, the Hollister device just won't fit for some reason, we have a catcher's mask. This is going to take a little bit of coordination with your team to get this in place. There's straps to secure to your patient's head. I would just tuck those out of the way to start. So what I'm going to do is I'm going to get my umbilical ties. These are going to be supplied in your kit. I'm again going to use a marker to mark my tube at the insertion site. So I would mark it close to the lips. You can tie a slip knot close to the lips around your tube. I would probably go ahead and go around with it one more time and tie myself a knot. Okay, so now I'm gonna have my partner remove weighted traction from the end of the bed, hold traction physically with their fingers at the patient's lips. And then we can remove weighted traction. We're going to feed this entire thing through the catcher's mask.
Through the lower.
The lower portion, yep. Not through the eye hole. There we go. Next, we need to pop our patient off the ventilator to get the ET tube through. So we can do that. Go ahead and put them back on. Eric's still holding tension with his fingers. Now I'm going to pull my ties through. And I can, tie my device onto my mask wherever it's closest to, wherever it's convenient. So pulling it a little bit and go ahead and tie it on there. And then Eric can let go. And we're gonna, again, check our measurement, check our placement. We can get our straps around the back of our patient's head and proceed with our transport. Once we are in the truck, we are going to want to put our device on suction. It was on suction at the bedside when we got there. So we want to continue suction to both those ports during transport. We're going to supply you with extra suction tubing and one of these suction splitters. So with both of your suction ports are going to be, you can put your suction on, and you're going to turn it to 120 in the truck, continuous suction. It's on intermittent suction at the bedside, but 120 continuous suction is what we're going to be able to do. You're going to have these kits in all of the trucks, which are going to have our modified Hollister holder, our Y splitter for the suction, your umbilical ties, and then a pair of scissors. In the event of airway occlusion, where you just need to get this thing out to prevent your patient's airway from becoming occluded, what you would do is cut with scissors through the entire device, deflate the balloons entirely, and then remove it. So that's it. Good luck.